Today I'll discuss the presentation of a young man who came to me with a complaint of a headache. He described it as a tension headache that had been present for 6 to 7 years for no apparent reason, so no strong mechanism of injury. He reported having headaches about 2 times a month on average that could last for several hours. It would be a band across his forehead, and very importantly, it would also present with neck pain across the base of his neck into his shoulders, left greater than right. And when someone says it's asymmetrical, or if I ask and I learn that the pain is more one-sided versus the other, I always ask in terms of percentage. So he said it was left to right 75 to 25. No complaint of arm symptoms, hand symptoms, or numbness or tingling. Medicine would help the headache, but he hadn't experimented with other therapies for it quite yet. In terms of getting worse, he was wondering if what made it worse was stress. Sometimes wearing a backpack could make it worse. Sitting for a prolonged time could as well. He noted that he himself felt stiff and that he himself had poor posture. He was a teacher, or is a teacher, so one part of his day, a big part of his day, is bending over and leaning over students. So it is a flexed or protruded position for the neck and upper mid-back. At home, he uses the laptop a lot, which is a similar posture. So his verbal history was pretty short, pretty sweet. The good thing about having very specific symptoms is that you can assess cause and effect more readily. The bad thing about not having symptoms when you come into the office, or symptoms that only present once a month or twice a month or once a week, is that it will take a little bit more time to see if what you're doing has an impact. So he kind of fits into that cohort of people. So moving on to the mechanical exam, this was a telehealth visit, so this was via video. Seated modified nerve tension tests for the upper extremities bilaterally were negative. Mechanical movements of the neck, there are 8. Protrusion was normal. Flexion was normal with neck tension. Retraction I put as minimal loss, with what he reported as a sensation of being very tight with tension. Extension I put as a minimal loss, no pain. Left rotation, minimal loss, tight. Right rotation, minimal loss with some pain on the right. Left side bend, minimal loss, tight. And right side bend, a slightly more min loss with some tightness. So most motions of the neck presented with not feeling great. There was no strength testing, and there was no real functional baselines we could use because, again, his headaches tend to come on every couple weeks and he doesn't really know how to make them come on. So we started with retraction. I started with retraction as the first repeated movement to use for the testing because of his limited retraction with pain or tension, and because headaches often come from the upper cervical spine and often have a beneficial response to retraction. It's not all, but it's the highest prevalence. So we started with retraction. We just did 2 sets of about 12. It produced neck pain and didn't linger afterwards. So in my vernacular, that's produce, not worse. And afterwards, his mechanical baselines of his neck movements were better. So he increased in side bend, increase in rotation, and I think an increase in retraction the more he did. So I made that his homework. So retraction, set of 10, at least 6 times per day, being aware of posture. We talked about posture, and adding overpressure at the end range of the retraction in a few days if he felt like his neck was able to handle it. One thing to note is that, of course, headache is a symptom. Ache is pain, is a symptom. There are many, many causes of headaches, but one of them is mechanical joint problems in the spine. So whether that's the neck or the mid-back, and if you separate the neck into upper, mid, and lower, there's a couple different areas we can look at. 2 things that can tip me off to this a mechanical problem being the source of the headache or an orthopedic problem being the source of the headache is if the initial injury that started the whole ball rolling was orthopedic. For example, if you got into a car accident and then you started having headaches, right? Or you fell or something more traumatic, that can be a tip-off that the likelihood of a mechanical problem creating the headache is stronger. But secondly, if there's also complaints that are orthopedic along with the headache, right? So in this case, he presents with neck pain as well as headaches, and he correlates the two, he associates the two. So that association is really strong versus, if you had headaches because of something in your brain or because of electrolyte imbalance or something like that, that would be less likely to present with neck symptoms as well. So I saw him a week later on telehealth. He had been doing his home exercise program 4 to 5 times a day. He had not had any headaches, but what was really helpful is that he said he felt like a headache was coming on once. He did the retractions and the headache stopped. So he also noted that he was more cognizant with his posture and at home. It wasn't perfect, but it was something that he could pay attention to. On the mechanical side of things, his movement was significantly better. I put nil loss for all planes of motion with a slight stiffness into right rotation. And none of these 8 movements caused tension or tightness or pain like they had a week prior. So he showed me how he was doing his home exercise program, the retractions. He did them well. He wasn't adding the overpressure, so we looked at adding overpressure, which increased his right rotation, decreased that stiffness into neck right rotation. Then I had him hold it for 10 seconds, which also had the right rotation better. So oftentimes with headaches, sustained procedures are more effective than repeated. Knowing that, I presented to him the option of, if you're not on track with this, doing it repeatedly with the overpressure to get fully to end range, now that I think it can handle it after a week, sustained is an option, and patients can hold it anywhere from a few seconds to a few minutes. It's really to the individual's tolerance and what benefits them the most. So I explained to him that sometimes going back and holding it in a retraction position for a while is the beneficial mechanical procedure, which is contrary to spending lots and lots of time sustained in protrusion. So it's from our discussion, he was happy with where we were, I was happy with where we were, and we left it that he would reach out to me if he didn't feel like he was making adequate progress. I laid out the procedures, the algorithm for him. Like, if this is mechanical, if we found the right motion, then this is what you should see. Better, better, better. Either able to keep headaches at bay or able to quickly turn them off. People have different goals. Some people have the bandwidth and the time and the energy to do motions prophylactically so that symptoms don't come on. Some people would rather, or for other circumstances, just be reactive. When stiffness or pain arises, they can turn it off. So every person's a little bit different in terms of what they're looking for. And there's a lot of lifestyle factors that factor into that equation. I don't really care what you want as long as you feel like you're getting what you want. But it's important to note that if you can find the diagnosis and if you can find something that at a minimum can ameliorate the symptoms and bring the headache from a 6 to a 1 and it's not impacting your life like it used to, that's great. But if you can do that, you can also give the patient an explanation. You can also give the patient a course of action and not have them seek other care, and take away their fear that something is really wrong with their head or really wrong with their neck, and just show them, like, look, this is what's going on. Until proven otherwise, this seems mechanical. It seems like an easy fix, especially in a young person, a person whose neck motion really, really improves in a week of just doing something 4 to 5 times a day for 30 seconds. So that's why I think understanding mechanisms and being able to give a strong argument for a diagnosis is so important, because if you have a strong argument for diagnosis A, then the person's not thinking about B, C, D, and E and all the other things that can lead to headaches and all the other anxieties and fears that come with that. We were in touch a few weeks later via email. He said he was happy with our program and he would reach out if he needs me. And that really can be the end of any successful episode of care, is if the person feels like they have a handle on their problem to their content, right, to the amount that they want, and that they don't have to seek other care, other opinions, and they know that person always knows that they can reach back out to me if progress plateaus or if their goal doesn't become realized in the next few weeks or months. But headaches at the end of the day are a symptom. We have to look for the root cause. There are many mechanical joint derangements that can be fixed with directional preference exercise. So moving repeatedly into one direction can be an answer, can be a diagnosis, and can be a treatment plan. Often it's moving the upper cervical spine, but it could be lower or mid cervical spine, as well as I've seen thoracic problems present with pain up into the head. So clinicians have to be considering that mechanical problems in the spine can be the root cause of headaches, especially when the onset was mechanical or orthopedic in nature, and especially if symptoms other than the headache are also in play, such as shoulder pain, neck pain, obviously, jaw pain, or stuff into the upper extremities or scapular areas.